Hello viewers and a very warm welcome. You're watching the brand new edition of India Fights Back with your host Kriti Mishra. Centre has dropped plasma therapy from COVID treatment protocol. COVID National Task Force has released new clinical guidelines for management of mild, moderate and severe COVID cases. Plasma therapy does not find a mention under the new guidelines. The decision came on the basis of recommendations of experts from AIIMS, ICMR-COVID-19 National Task Force and Joint Monitoring Group of Union Health Ministry. Members of the ICMR-National Task Force for COVID-19 met on Friday to deliberate upon the effectiveness of plasma therapy, which gained momentum last year during the onset of the pandemic. However, in the recent meeting, all the members of the task force were in favor of removing the use of plasma from the clinical guidance for management of adult COVID-19 patients, citing its ineffectiveness and inappropriate use in several cases. Indian Council of Medical Research has said that they will issue an advisory on the matter very soon. And for deeper insights on the topic, I'm joined by distinguished guests on the panel today. Joining me on the program, Dr. Aparna Mukherjee, Scientist Aide, Clinical Trial and Health Systems Research Unit, ICMR, and Dr. Arvind Kumar, Associate Professor, Department of Medicine, AIIMS, New Delhi. Welcome to Raj Sabha Television, both of you. And Dr. Mukherjee, coming to you first, and before we talk about what happened, what is the latest guideline and why the plasma therapy has been dropped, tell us what is the COVID convalescent plasma therapy? Help us understand the basics of it.
Okay, right. So convalescent plasma, as we are talking of now, is basically plasma that we collect from patients who have had COVID-19 and have recovered from it. And so we expect that they would have antibodies in their plasma, which is developed in their body, which is developed to fight against the virus. So when we are taking plasma, we are basically transfusing these antibodies to another patient in the hope that these antibodies will help in fighting the virus in that patient. So this is a form of passive immunity that we are providing to the patient till he or she actually develops his own immunity.
All right, Dr. Kumar, you would like to add to that?
Yes, very rightly said. Basically, when the pandemic began and we had some initial glimpse of some evidences gathered from various institutes that if you give antibodies already formed in someone who is already treated and he has out of COVID problem, and if you provide the plasma of that patient with an adequate amount of antibodies against COVID virus to a patient who is now progressing into moderately from a moderate disease to a severe disease, that means early moderate disease. So at that point of time, it was found that if given very judiciously, so there was some signs that it may benefit to a patient, it may benefit. So based on those initial clinical experiences, this was incorporated in various societies, various educational bodies guidelines to give at a particular point. But as the time passed and we realized that, I'm putting this in the standard treatment guideline, the use was inaberrant, the use was unjudicious, and many a times rather than getting benefit out of it, there were major side effects which can be always there with infusion of plasma in any patient with other disease also, that could be easily seen, and they can cause life-threatening events. So citing those things, it was realized that better that we should take it out from standard treatment guidelines. But yes, there are some few corners left where, there is a possibility that you can use it as an experimental and a trial basis, but not as a standard treatment protocol.
All right, not as a standard treatment protocol. And let me take that to Dr. Mukherjee. Dr. Mukherjee, as we understand that the plasma therapy, which includes transfusion of COVID-19 antibodies from the blood of a recovered patient to the one being treated, it has not been found effective in reducing the progression to severe diseases, nor has a decrease in the fatality rate been observed. What is your take, ma'am?
Yes, as Dr. Arvind was saying, that initial phases of the pandemic, there was a lot of excitement regarding this therapy because this is something that has been used in other infectious diseases as well. So since we did not have any other means of tackling COVID-19, so this appeared as a good option that if we can transfuse plasma with enough antibodies, then it would be helpful. But as time has progressed and we have seen that it is being used indiscriminately at any stage, a critically ill, mechanically ventilated, gasping patient receiving plasma is not really going to help because it's primarily an antiviral effect it has. So there has to be viremia. You have to have it in the earlier phases when virus is the problem, not the inflammation. And gradually, there have been more studies as time has progressed. There have been larger studies which have actually shown that same thing, that if like given in order to halt the progress from severe, moderate to severe, or to prevent mortality, it is not showing any therapeutic benefit. So that is why we, the whole group of experts, decided that to take it out from the standard treatment protocol as is being said, that so that indiscriminate use can actually be to some extent curbed.
Absolutely. But you're also telling us about the usage of plasma therapy. Otherwise, Dr. Kumar, where did we use plasma therapy? In what all illnesses and diseases?
Yeah, I deliberately wanted to mention this at this point of time. So, what is happening that any treatment, as all of us, I mean, everyone is growing and learning, I mean, last 2 years have been very, very, very challenging, and still we are growing. Every day we are growing. So if you ask me about plasma in one line, that is this chapter completely closed? Are we at a position to say that no, plasma is completely nowhere of use, completely denying anything, any possibility about plasma? So we have such data, larger data with enough sample size, with enough statics. So the answer to this would be a no. But whatever we have available till date says that we should not use it, not non-judiciously, inaberrantly, because it may cause more harm than benefit. Now, saying this and realizing this, that this whole syndrome, as my colleague told, that is at a spectrum from mild to moderate, and then to severe. And you have a phase where you are not fighting with a virus, you are fighting with the aftermath effect of the virus, that is called inflammatory syndrome. And that is rather more, devastating than virus itself. So in initial phase, when you are at a point where we are moving from mild to moderate, that is very, very important. It's a very gray zone area at this point in time. Let me tell you very frankly, from mild to moderate, it's a very gray zone area. Now, you have moved from mild to moderate, and you are in a very early, early moderate phase. So at that point of time, in certain group of patients, like elderly, where you are very sure that in this particular person, he or she was not exposed, and there would be no evidence of any antibodies, or he was not vaccinated, already inside the body. So what we say, that there could be a possibility that it may help in very early phase of moderate disease. So saying this, I again repeat my stand that it has to be clinically justified, used very judiciously with all safety, seeing its all parallel side effects, and the overall fitness of the patient. So once we talk of a guideline, once we talk of a treatment guidelines for everyone, for every physician out there, we don't put such kind of things which may cause harm. So yes, so we have to take it off. But yes, the corner is open in a selective group of patients, where you might take a decision clinically, that where you feel that I am not getting benefits from other standard line of treatments, I may try. But yes, it's only and only for a case-to-case basis, and in a specific scenario, not in a generalized manner.
So case-to-case basis and not in a generalized manner. That's a very important point that you're making, Dr. Kumar. But Dr. Mukherjee, I'd also like to understand, how did we arrive at this conclusion? Of course, we understand that there is no confirmation on whether plasma therapy really cures a COVID patient or not, but what are the studies that we undertook to arrive at this conclusion?
Right, we've had multiple RCTs, that is randomized controlled trials from across the world regarding this, starting from last year itself. So we had one which was done in India with across India, across 39 centers actually, which included about more than 400 patients, and there also we did not find any benefit in mortality or in progression to severe disease. But yes, that study did have a flaw that we did not measure the antibodies a priori, that is before the study, before giving it, and so therefore a percentage of plasma did not have enough antibodies. So then again, there have been other studies like the recovery study from UK, which is a large one, which is the same platform where we got the dexamethasone verified. And so this platform had around 11,000 patients who were divided into two groups, the ones who got the plasma and did not get the plasma. And these were all very high titer plasma, that is with a lot of antibodies. And there also they could not really show any difference between mortality here, the one in the group that got the plasma and the one that did not get the plasma. It was in fact 24% in both the groups, exactly the same. And there are some smaller studies from Argentina and Brazil, which also show similar effects. Again, like my esteemed colleague was saying, there is one from Argentina, which again is showing that if you give it within 72 hours in elderly patients who haven't developed their own antibodies, it might be helpful. It might be helpful in reducing the mortality. So usually when we have so many RCTs, they are pooled together. So that's a meta-analysis where all the data is pooled together and then analyzed. And so these kinds of analysis, when we went through them, even without the recovery data, the other RCTs that were there, that did not show really, and if we just use it for every patient, it's not really showing any benefit in reduction in severity or in mortality. These are the hard endpoints that we are interested in. So that taking in view these evidences, this decision was reached.
All right, and also the fact that the principal scientific advisor, K. Vijay Raghavan, cautioned against the irrational and non-scientific use of this plasma therapy. Dr. Kumar, this certainly assumes a lot of importance, this particular statement made by the principal scientific advisor.
So see anything, the changes in our, there are these all letters. I'll tell it as a scientific input. So someone would have written a letter citing something that it is causing some problem in certain group of patients somewhere, which was very well taken. So any criticism, or I think I will say it's a scientific input by anyone. So the letter written by such a great person to a research, organization, citing some issues with it, and then all the responsible persons sat together. They realized that this is a very well said kind of thing. So we should be, striking it off as far as our standard broad treatment guidelines are concerned. Saying same, at the same point of time, I must say that we should rather stress more on the current evident standard treatment guidelines like steroids, judicious use of steroids, anticoagulation, oxygen, which are definitely life-saving, which have definite mortality benefit. So rather the stress, once we take out from which has some corners which are really doubtful, so we should move from a doubtful towards a definitive treatment. So these kind of steps also helps in gaining the same things, So these, I think, I would take it as a very in a positive note that such comments and were made, and it was taken very positively.
All right, but the fact that some experts have also asserted that it is helping in promoting mutations and variants, Dr. Mukherjee, how do you justify that? What is your take?
That is a theoretical possibility that if we give plasma with and it is not being able to neutralize all your viruses, there might be immune escape and there might be variants developing. So till now we only have case report on immunocompromised patients where after a prolonged period once the plasma was given, some mutant escape was seen. Similarly, we have some in vitro studies, that is in the laboratory studies, which has shown that after multiple passages, there has been some variant development. But as I said, this is a very theoretical domain till now, and we really don't have much evidence that the use of plasma itself is causing mutation, because mutation in virus is a very normal procedure. So even if you don't treat the patient, don't give anything, gradually the virus is going to mutate. And particularly so coronaviruses are known to do that. So yes, that is a concern, but that is not the main concern that was regarding plasma therapy. It was more that we were giving all our resources to something that we are not really sure is working. Like Dr. Arvind said, there's oxygen, anticoagulation, steroids, and proning, ventilation later, good monitoring. These are the things that we really need to focus on, because we know these are going to save lives.
Absolutely. But mutations and variants, of course, that's a very important part. Dr. Arvind, I'd also like to elicit your view on that.
See, mutations are going to happen definitely on all viruses. See, like we want to survive, virus want to survive. And for that mutation to occur, you have to give your body, I have to give my body. So they need a place where they can mutate. And by nature, every creature on this earth tending to survive. So for surviving, these kind of mutations will take place. Whether you treat and whether you give any treatment, they will try to mutate because they want to survive. So my message and my one-line message to whole world and all our viewers would be that the initial, preliminary signs of not giving your body to the virus by simple means of hand hygiene, distancing, mask wearing, so that virus not find a place to mutate. So no, mutation is going to happen, and mutations is very difficult to curtail down. The more and more chances, the more and more, way you find out of treating a virus, viremia, they will find their ways to get mutated.
All right. Okay. Since we're talking about plasma therapy, Dr. Mukherjee, what are the other known risks of this therapy? Otherwise, not in COVID, but otherwise in other diseases.
Right. For any biologicals, any blood products that we are giving, there are some risks. So for plasma, even if you're not giving it in a COVID-19 patients, there would be certain adverse events which might happen, like you may have lung injury, acute lung injury, you may have allergic reactions, you may end up with volume overload. So these things might be there even irrespective of whether your patient is suffering from COVID or COVID-19. So this is a risk that is taken whenever any biological blood products are given. But most of the hematologists and the intensivists and the physicians, they are well aware of these risks and they know how to monitor this risk and how to counter them when these happen.
All right. We've also seen over the last year that there are a lot of people who have enthusiasm for donating plasma. Dr. Arvind, after this new protocol, what is your message to them?
See, in all the institutes which are research-based institutes, which are academic institutes, which are institutes which are, they are dynamic in their management protocols. They know very well what Dr. Aparna rightly told, that it has got some side effects which can be very life-endangering at times. So viewing that, I would say that wherever these kind of treatment protocols are in a stage where we are still learning, where we are still finding our ways to give maximum benefit to the patients, because we are doing everything, even then we are losing our patients. So there could be scenarios, there could be stages where we may require this kind of treatment. Let's say it's experimental, it's still experimental, but yes. But citing a possible amount of benefit, if our institute is demanding and their employees or the patients who have recovered are eager to donate, so there should be no discouragement as far as I'm concerned in saying this, because initially I told you that are we closed completely at this date, that we are saying a big no to this? So my answer to this would be a no. because Dr. Aparna told that we are still, we have a good data, but we want to have a better data. We want to give it a meta-analysis shape. We want to gather more and more information. We want to have a larger sample size. So viewing this, I still feel that it should get a corner in less than 7 days, very early moderate disease, elderly patients who are devoid of antibodies, which we think that it could be there in majority of patients at this point of time, because we are already exposed too much, and then there are a large number of patients who are already vaccinated. So I will give you it a little credit in a academic and research institute that where it could be beneficial if the clinical teams managing the patients in a case basis finds that we are not winning with other means, standard means, and we can try this to give some benefit to the patient.
All right, Dr. Mukherjee, do you agree with Dr. Arvind?
Yes, it is always the physician's prerogative finally. It is his or her discretion finally as to what treatment needs to be used in a particular patient. So he pulls on his own expertise and knowledge to decide that. Guidelines are meant for as recommendations, as assistance for everybody to know that this is the evidence and this is how you could go on. They are not actually rules per se. So that's the thing. And yes, they might be very niche and you have to use your clinical judgment to actually see whether there will be any benefit or not. But I'm reiterating that using it as a last ditch effort when people are really critically ill and mechanically or non-mechanically, non-invasively ventilated, like you just want to try out something, that is not going to help, because there is scientific plausibility is not there for it to help. By that time, your virus is not there in your body. It's your inflammation, and the plasma cannot help there.
Yes, a big no to that. A very, very big no to that, ma'am. So, genuinely speaking, because at this stage where patient is at very high flow of oxygen, or devices which are, patient is already very much dependent in a good amount of oxygen, or is intubated invisibly, or even in non-invasive ventilation. So at that point of time, rather than, supporting the patients by giving these kind of treatment, you are creating more and more problem. So the problem is going to get increased if you are giving a plasma therapy. Absolutely a big no at this point of time. But yes, I just told that at a very early moderate disease, with the inputs of all the teams, the hematologist, the clinical, physician, all the teams, the critical care specialist, at that point of time when, you can possibly, if you find that there is a benefit, you can. Otherwise, in critical patients, a big no.
All right. Okay. So that's the broad consensus that we have on the show. But time for closing comments from both my guests. Dr. Mukherjee, coming to you first. Every step taken should absolutely be based on evidence and on research. Your closing comments looking at the COVID-19 situation in the country.
Definitely. And this pandemic has really shown us how evidence-based medicine can help us and how we can really interpret it and use it in our daily practice. But again, I would like to say that for a disease where we are, really struggling to find something to treat it with, prevention would be the best cure. So this is our collective responsibility that we maintain all the COVID appropriate behaviors like hand hygiene, masking, distancing, however insane and however fatigue inducing it might appear, we absolutely need to adhere to that.
We have to adhere to the COVID appropriate behavior. Absolutely, ma'am. And Dr. Arvind, your closing comments on the show today.
So, so prevention is there. So nothing can substitute that prevention part. But yes, in a plasma kind of, conference with we three people, I would rather say that stick to whatever is known to us. Stick to basics. If you are affected, get in connection with your local physicians. Don't run for a hi-fi kind of thing. Get yourself monitored well with oxygen saturation, with your CRPs done at per days. Monitor yourself very closely, hydrate yourself very well, and then if at all your problem increases, then that is 5th, 6th, 7 days are critical days. If any problem increases, try to be early, getting these facilities from a medical care hospital, and then that will curtail your problems to go into high, moderate, or severe disease. So my take on this would be that from the first day, you should be very uh, attentive. You should be very sincere that you bring your problem to a medical personnel around you, near you, so that he can monitor you very well.
Yes. And as they say, prevention is better than cure. So it is incumbent upon all of us to follow the COVID appropriate behavior. On that note, thank you so much for joining us on this show.
Thank you.
Thank you.
Well, viewers, that's all we had for you in this edition of India Fights Back. But before that, let me remind you once again to stay safe from the coronavirus pandemic. Remember to wear a face mask and wash your hands and face regularly, and ensure that you maintain physical distancing whenever you're stepping outside. Well, these simple precautions are all it takes to defeat this pandemic. Take very good care and goodbye.